Hello everybody, dear colleagues. Department of Endocrinology at Tbilisi State Medical University presents a lecture, Diabetes Complications, Part 2, Diabetic Neuropathy. Lecture is given by the head of the Endocrinology Department of Tbilisi State Medical University, Professor David Metrovelli. What is diabetic neuropathy? Diabetic neuropathy is a common complication of diabetes and cause of considerable morbidity and increased mortality. Diabetic neuropathy is not a single entity but encompasses several neuropathic syndromes. The Toronto Diabetic Neuropathy Consensus Panel defined diabetic peripheral neuropathy as a symmetrical, length-dependent sensorimotor polyneuropathy attributable to metabolic and microvascular alterations as a result of chronic hyperglycemia exposure and cardiovascular risk covariates. An abnormality of nerve conduction test, which is frequently subclinical, appears to be the first objective quantitative indication of this condition. And the occurrence of diabetic retinopathy and nephropathy in a given patient strengthens the case that the polyneuropathy is attributable to diabetes. The development of the study of the problem of diabetic neuropathy in Georgia had a long tradition. Particularly successful was the collaboration of specialists from the Tbilisi Institute of Neurology with endocrinologists from the Tbilisi State Institute of Postgraduate Medical Education. The results of these collaborations were summarized in a series of publications in central medical journals, in the reports of congresses and conferences, and in the monograph Diabetic Neuropathy. Here in this picture we can see this book, Diabetic Neuropathy, which was issued in 1974, many years ago. The initiator of this scientific work and the leader of the group of authors was the great Georgian endocrinologist, academician Vaja Lekishvili, Vaja Iverieli. In this picture you can see it's a photo of Vaja Iverieli. The monograph of Vaja Lekishvili Iverieli and co-authors was devoted to the study of the pathogenesis of diabetic neuropathy. For many years, there has been an universally recognized microangiopathic theory for the development of diabetic neuropathy. Such mechanism of damage of the peripheral nervous system exists, but it's not universal. In this monograph, Vaja Lekishvili and co-authors presented clinical evidence in support of the metabolic theory of the pathogenesis of diabetic neuropathy. Diabetes mellitus is the most common cause of the neuropathy worldwide and is becoming an increased burden in countries in which the prevalence of obesity is rising. Most of the clinical manifestations of diabetic neuropathy were identified during the second half of the 19th century, but our knowledge regarding the pathology of diabetic neuropathies has increased more recently by the unexpected findings of inflammatory lesions in the focal diabetic neuropathies. In this lecture, we will consider the clinical pathological aspects of the various patterns of diabetic neuropathy, starting with length-dependent diabetic polyneuropathy, LDDP, which is by far the most common type of diabetic neuropathy. We will also consider the focal diabetic neuropathy and discuss the diagnosis of chronic inflammatory disseminating polyneuropathy, which should not be missed or confused with diabetic neuropathy when it occurs in patients with diabetes. WHO estimates that in 2019 diabetes affected approximately 463 million people in the age group from 20 to 97 worldwide. There is reason to believe that about 45 million people worldwide are affected by symptomatic diabetic neuropathy. Growing rates of obesity and the associated increase in the prevalence of type 2 diabetes could cause the figures to rise by 1.5 times more than by the year of 2045. Here you can see the data of IDF, International Diabetes Federation, about prevalence of diabetes in different regions of the world, in the different continents, in America, in Asia, in Africa, and in Europe also. So the prevalence of diabetic neuropathy also increased with time and poor glycemic control. Severe diabetic polyneuropathy can develop in young adults within a few months after the onset of type 1 diabetes if the diabetes is poorly controlled. Classification of diabetic neuropathy. Since the first classification suggested by the Leiden in 1893, many other classifications were proposed over the years to capture and categorize the different clinical and neurophysiological manifestations of diabetic neuropathy. The American Diabetes Association recommends the following classification in his position statement on diabetic neuropathy. It's a recommendation of American Diabetes Association. So, diabetic neuropathy. The first is the so-called diffuse neuropathy, DSPN, distal symmetric polyneuropathy. It's a primary small fiber neuropathy and primary large fiber neuropathy, and also mixed small and large neuropathy, fiber neuropathies, mixed small and large fiber neuropathy. It's the most common. The next is so-called autonomic neuropathy. Also, it's a manifestation of diffuse neuropathy. It may have cardiovascular manifestations, and among them, reduced heart rate variability or resting tachycardia, or orthostatic hypotension, and sudden death because of malignant arrhythmia. Another manifestation of autonomic neuropathy is the gastrointestinal manifestation, diabetic gastropathy, or diabetic enteropathy, diarrhea, and colonic hypomotility, constipation. Manifestation of autonomic neuropathy from urogenital sphere, diabetic cystopathy, neurogenic bladder, and erectile dysfunction, and female sexual dysfunction. Pseudomotor dysfunction also is the manifestation of autonomic neuropathy, distal hypohidrosis or anhidrosis, and gustatory sweating. In case of autonomic neuropathy, very important, hypoglycemia anovariance and abnormal pupillary function. Another part of this classification is the mononeuropathy. Mononeuropathy is multiplex atypical forms, isolated cranial or peripheral nerve damage, and mononeuropathy is multiplex if confluent may resemble polyneuropathy. Radiculopathy or polyradiculopathy, also a typical form, radiculoplexus neuropathy, and thoracic radiculopathy. And at last, the non-diabetic neuropathy is common in diabetes. Pressure pulses, chronic inflammatory demyelinating polyneuropathy, and radiculoplexus neuropathy, acute painful small fiber neuropathies. It may be treatment-induced. Clinical aspects of diabetic neuropathy. Length-dependent diabetic polyneuropathy. It's a chronic length-dependent diabetic neuropathy, it begins in toes or feet. Stocking distribution progress rostally, tops and bottoms of feet. Weakness begins in ankles when sensation reach calves. More than 80% of patients with clinical diabetic neuropathy have a distal symmetrical form of the disorders. In these neuropathic patterns, signs and symptoms start and remain more pronounced in the feet and go on to affect more proximal parts of the lower limbs and eventually this part of the upper limbs, indicating that the longest nerve fibers are affected first. Shorter sensory axons subsequently became involved, accounting for neuropathic manifestations in more proximal parts of the limbs and eventually in anterior trunk. This is often referred to as a length-dependent pattern. Progression of polyneuropathy is not specific to diabetes, also occurring in alcoholic and amyloid polyneuropathies. LDDP usually became symptomatic several years after the onset of type 1 diabetes, but can often also reveal diabetes of mature onset. Inaugural symptoms of LDDP include numbness, burning feet, pains and needle sensation, and lightning pains. The symptoms are often most pronounced at night, and the burning pains can be exacerbated by the contact. It's a different illustration of the pain during diabetic neuropathy. The sensory neuropathy can be totally silent and detected only by systematic neurological examination of the feet, or can be revealed by painless trauma or burns, or by trophic changes that include plantar ulcer or neuropathic osteoarthropathy, so-called Charter's arthropathy. It's in the picture we can see the leg of manifestation of Charcot's arthropathy, and it's a manifestation of diabetic blister. The distal symmetrical sensory loss can be restricted to the toes, extend over the feet, or spread over the lower legs, or higher above the knee level, depending on the intensity of peripheral nerve lesion. When sensory loss extends above knee level, it develops over the fingers and spread up over the hands and the forearms while progressing proximally in the lower limbs. Later on, the entire aspect of the trunk can become affected owing to the involvement of the distal territory of the sensory nerve fibers or the intercostal nerves. In the most severe cases, the summit of the scalp can be affected as a consequence of the involvement of the longest fiber of the trigeminal nerve, and in exceptional cases, the loss of sensation can spread over the almost whole body. Eventually, all modalities of sensations are lost in the distal part of the lower limb, whereas superficial sensations, especially temperature and pain sensations, are predominantly affected in the proximal regions. Thermosensibility can be reduced in isolation or in combination with loss of vibration sense, but selective loss of vibration sense is real. The maximum dissociation between functions of small and large fibers, small fiber functions are heavily affected, whereas large fiber functions are spread, occurs in so-called pseudo-syringomyelic type of diabetic neuropathy. Small fiber sensory neuropathy presenting with reduced intraepithelial nerve fiber densities and correlated elevation of warm threshold is also a major manifestation of type 2 diabetes. In small fiber LDDP, the length-related sensory loss mainly affects pain and temperature sensations and leads to the occurrence of painless burns, persistent foot ulcer, and neuropathic osteoarthropathy. In these cases, prominent autonomic disturbances are also present, suggesting simultaneous alterations of the autonomic unmyelinated fibers. It's a list of clinical presentation of small fiber neuropathy. Loss of large myelinating fibers and other proprioceptive afferent fibers leads to disturbance of light, touch, sensation, sensibility to pressure and vibration, and joint position sense. Disturbance of joint position sense can result in increased instability or posture with, in the most severe cases, a positive rhombic sign and ataxia. Here you can see the illustration of polyneuropathy mobility issues. Also, this pseudo-diabetic pattern of diabetic neuropathy was recognized more than a century ago at a time when there was no treatment for diabetes. It seems to be rare nowadays, at last, in industrialized countries. Distal weakness is a late event in the natural history of LDDP, and distal weakness and wasting can be observed in association with severe sensory loss in this setting, but predominantly motor neuropathy is not a feature of distal neuropathy in patients with diabetes. Established LDDP is irreversible despite improvements of metabolic markers. At best, the sensory deficit can remain stable or worsen slowly over time. Strict glycemic control is associated with a lower risk of deterioration of the neurologic condition, but serious complications commonly occur in the course of LDDP. Painful symmetrical polyneuropathy. Neuropathic pain is a major burden on diabetic patients and is a common complication of LDDP. The occurrence of different types of spontaneous pain in hyperalgesic diabetic polyneuropathy had been recognized by the end of the 19th century. Painful symmetrical polyneuropathy. In spite of several attempts, however, it has not been possible to ascribe the occurrence of pain to specific morphological findings. Recent studies of intraepidermal nerve fibers show that more severe loss of these fibers was associated with the presence of neuropathic pain only in patients with little or no objective signs of neuropathy. Consequently, loss of IENFs cannot explain pain in all cases, suggesting that different mechanisms underpin the genesis of pain at various stages of neuropathy. From a physiological point of view, however, microneurographic recording from unmyelinated fibers of diabetic patients with painful and non-painful neuropathies revealed an abnormal ratio of mechanoreceptive and mechanoresponsive to insensitive nociceptors or in patients with diabetes, suggesting that the mechanoresponsive nociceptors had lost their responsiveness to mechanical stimuli and had small fiber neuropathy in diabetes. Therefore, seems to affect the receptive properties of nociceptors, leading specifically to impairment of mechanoresponsive nociceptors. Recent developments in our understanding of pain receptors have shown that transmission of painful stimuli depends on activation of sodium channels that are expressed in high levels in cell membrane of nociceptive neurons of dorsal foot ganglia. The identification of mutations of the gene coding for a sodium channel in patients with familial insensitivity to pain indicates that the response to painful stimuli is to some existing genetically determined. Painful symmetrical polyneuropathy. Acute painful neuropathy with allodynia is sometimes associated with cachexia and depression, especially in young adults with type 1 diabetes. Acute painful neuropathy rarely precipitates once tight glycemic control has been established. Trophic changes in distal symmetrical sensory polyneuropathy. Trophic changes predominantly affecting the distal part of the lower limb are a major complications of LDDP. The earliest change is frequently a callus, often in the region of the metatarsal heads, which might occur despite regular foot care. In other cases, the first manifestation is a painless fleece canal lesion. Both of these conditions are painless and are associated with loss of pain sensation over the feet. Chronic ulcers can subsequently develop. Idiopathic bullae, which can precede the onset of plantar ulcer, can occur in territories with sensory loss in the hand. Neuropathic osteoarthropathy is a complication of long-standing diabetic neuropathy. Painless foot deformity, sometimes of acute onset, is the main sign of this condition. On X-ray, the feet can show the following features: increased radial transparency, painless fracture, especially affecting the metatarsal bone with disruption of articular surface, disorganization of joints, especially the metatarsal phalangeal joints, and penetration of bacteria through neuropathic ulcer can lead to chronic osteomyelitis. Foot ulceration and neuropathic osteoarthropathy are not specific to the diabetic foot. Similar complications of loss of pain sensation occur in a number of conditions, including leprosy, hereditary sensory neuropathies, alcoholic sensory polyneuropathy, and hereditary indifference of pain with normal nerve biopsy finding. Loss of pain sensation with preservation of normal muscle strength or with subnormal strength can lead to painless trauma and development of plantar ulcer and osteoarthropathy. Vasculopathy seems to be an additional risk factor for trophic changes in patients with diabetes. Autonomic neuropathy. Autonomic dysfunction is one of the characteristic manifestations of diabetic neuropathy and can be life-threatening. Clinical cardiovascular disturbances usually start with resting tachycardia. The heart rate might return to its normal value later on, but does not exhibit normal variations in response to changing physiological situations. Postural hypotension, a fall in systolic blood pressure of more than 30 millimeter mercury, on changing from a lying to standing position without an increase in heart rate, can be an extremely disabling symptom of autonomic neuropathy with postural syncopes. Postural hypotension can be aggravated by tricyclic antidepressants, which are often used for treatment of chronic pain in diabetic neuropathy and episodes of diarrhea. Cardiac autonomic neuropathy seems to be strongly associated with increased risk of silent myocardial ischemia and mortality. Gastroparesis, which is a common manifestation of disturbances of alimentary tract function, is often asymptomatic but is at times revealed by a sensation of wholeness or less commonly be vomiting. Gastroparesis might result in poor glycemic control with hypoglycemia occurring because of stagnation of elements in the stomach. Diabetic diarrhea occurs at night or after meals and is watery. The diarrhea can be accompanied by fecal incontinence. Bladder atony leads to the presence of large residual volume after micturition, sometimes complicated by infection. Retrograde ejaculation is frequent in patients with atonic bladder. Impotence, which can be evaluated by the continuous nocturnal monitoring of pineal tumescence and rigidity, is a common complication in male patients with diabetes. Vascular and psychogenic factors as well as aging might also contribute to impotence. Erectile dysfunction is a common complication of diabetes mellitus, resulting from autonomic neuropathy, vascular disease, or more often a combination of both. Acute illness, for whatever reason, can lead to transient impotence. Sexual dysfunction is also a feature in women, though its management is not yet clearly determined. Incomplete erections are a common presentation in diabetes mellitus. Another symptom is absent emissions caused by retrograde ejaculation or in patients with autonomic neuropathy. However, erectile dysfunction in diabetes mellitus had many causes, including anxiety, depression, alcohol excess, drugs, primary or secondary gonadal failure, and hypothyroidism, and in some common with age. History and examination should focus on these possible causes. Erectile dysfunction, it's important to distinguish psychogenic versus organic causes. There are different manifestations of psychogenic causes and organic causes of erectile dysfunction. If left untreated, hypoglycemia could complicate autonomic neuropathy owing to failure of catecholamine release. Abnormal pupillary responses, the most striking signs of which are miosis and reduced light reflexes, are common in patients with diabetes. Focal and multifocal neuropathy. Focal and multifocal neuropathies are much less common than LDP in patients with diabetes. These forms of neuropathy are usually seen after 50 years of age and mainly in patients with type 2 diabetes. Focal neuropathies include cranial nerve involvement, limb and truncal neuropathies, and proximal diabetic neuropathy of the lower limbs. Development of sensory motor deficiencies in the territories of one or several nerve trunks or roots or plexus is rare in patients with diabetes and warrants exclusion of other causes of neuropathy by nerve biopsy if necessary. Cranial neuropathy. Cranial neuropathy in patients with diabetes is restricted largely to unilateral oculomotor nerve pulses. Third and sixth cranial nerve pulses seems to be equal in prevalence. heralded by transient frontal pain in around 50% of cases. The onset of cranial neuropathy is usually abrupt, with progression of the deficit occurring over 1 to 2 days. In third nerve palsy, the oculomotor dysfunctions is usually nearly or fully complete. Fourth nerve palsy is supposedly rare in this setting. Also, it can be seen in association with third nerve palsy. It's a manifestation picture of left, 6 cranial nerve palsies, paralysis, and also right, third cranial nerve palsy. No sensory deficits have been observed in the territory of the trigeminal nerve. In patients with third nerve palsy, it is advisable to perform a brain MRI scan and a magnetic resonance angiogram to exclude other causes of oculomotor nerve palsy. Patients with diabetic oculomotor nerve palsy recover spontaneously within 2 to 3 months. Also, relapses on this opposite side of the body can occur. Multiple cranial nerve palsies are extremely rare. 2 serious section studies performed in patients with third cranial nerve palsy demonstrate a centrovascular lesion of the nerve in each intracavernous portion. The fibers at the periphery of the nerve trunk were relatively spared, which accounted for the sparing of the pupillary reflex. In both reports, the authors suggested that the observed centrovascular lesions on the third nerve were likely to be ischemic in origin. Truncal neuropathy. Truncal neuropathy is usually predominantly or completely unilateral. The onset is abrupt or rapid, with pains or dysesthesia in the main features. The pain often has a radicular distribution and is almost always worse on contact and at night. Weakness of abdominal muscle also occurs. Isolated involvement of peripheral nerves of the limbs is extremely rare, with the exception of median nerve entrapment in carpal tunnel syndrome. Here's the localization of the manifestation of the trunk. Proximal diabetic neuropathy of the lower limbs. Patients with diabetes can present with proximal neuropathy of the lower limbs, characterized by a variable degree of pain and sensory loss associated with unilateral or bilateral proximal muscle weakness and atrophy. This syndrome, which was originally described by the Browns in 1980, has subsequently been reported using different terminology. The onset is acute or subacute, and the patient complains of numbness or pain of the anterior aspect of the site, often of the burning type, and most pronounced at night. The patient experiences difficulty of walking and climbing stairs owing to weakness of the quadriceps and iliopsoas muscle. Wasting of the quadriceps muscle and loss of the patellar reflex occurs at an early stage in the disease. The syndrome progresses over several weeks or months in most cases. Then it stabilizes and spontaneous pains decrease, sometimes rapidly. In approximately 1/3 of patients with PDN of the lower limbs, there is a definite sensory loss over the anterior aspect of the trach, and in these others there is a painful contact dysesthesia in the distribution of the cutaneous branches of the femoral nerve without definite sensory loss. The long-term prognosis is good, regardless of the quality of glycemic control. The clinical features of PDN, with its frequent motor involvement, asymmetry of the deficient, and gradual yet often incomplete spontaneous recovery, differ markedly from those of LDDP, in which motor signs are seen only in extreme cases and in which the condition never improves. Multifocal diabetic neuropathy. In a small proportion of patients with diabetes, a multifocal diabetic neuropathy, MDN, is observed with successive involvement over several weeks or months of full roots and nerves of the lower limbs, trunk, and upper extremities, sometimes with a relapsing course. The distal part of the lower limbs are invariably involved unilaterally or bilaterally, and there are also proximal deficits in most patients. Truncal and upper limb nerves are less commonly affected. The cerebrospinal fluid protein levels is increased in most patients. Electrophysiological testing demonstrates an external pattern. Multifocal neuropathy is by no means specific to diabetic patients, underlying the need to exclude a superimposed case of neuropathy in these settings. Distal symmetrical diabetic neuropathy. Abnormalities reported in diabetic neuropathy include external degeneration in nerve fibers, primary demyelination resulting from Schwann cell dysfunction, secondary segmental demyelination related to impairment of the external control of myelination, remyelination, proliferation of Schwann cells, atrophy of degenerated bands of Schwann cells, onion bulb formations, and hypertrophy of the basal lamina. Dying back fibers and fibers with distal sprouting of the proximal stump subsequent to degeneration of the distal axon have also been identified in LDDP. Axon loss predominates distally, and there is no correlation between axon loss and demyelination on nerve biopsies. Early morphological changes include minimal alterations of myelinated and unmyelinated fibers and axonal regeneration. Genetic factors might explain why some individuals develop a more severe polyneuropathy than others with similar diabetic status. And polymorphism of the gene, which called the eldest reductase and strongly associated with hot thermal threshold discrimination in patients with type 1 diabetes. Endoneural capillaries often show signs of diabetic microangiopathy with marked thickening of the basal lamina. The presence of multifocal nerve lesions and alteration of endoneural capillaries have indicated a role for circulatory factors in symmetrical diabetic neuropathy. Dissociated sensory loss, severe autonomic dysfunction, and predominant loss of unmyelinated axons cannot, however, be explained by nerve ischemic alone. Pathophysiology of diabetic neuropathy. Recent studies in patients with impaired glucose tolerance provide important insights into the role of the degree of glucose metabolism in the development of neuropathy. The deleterious effect of hyperglycemia is confirmed by the occurrence of neuropathy associated with impaired glucose tolerance. In this setting, the neuropathy is milder than its newly diagnosed diabetes, and small nerve fibers involvement is the really earliest detectable sign in the neuropathy. Accumulation of polyols, which is observed in animal models of diabetes, also occur in humans, but whether the accumulation of polyols in nerve leads to neuropathy is not established. Most of those reductase inhibitors tested to treat diabetic polyneuropathy have failed they produce any clinical improvement. In 2006, a study in an adult diabetic cohort showed that the AKR1B1 polymorphism might influence the decline of nerve function. The potential role in diabetic neuropathy of mitochondrial of sensory neurons located in dorsal root ganglia has been suggested by several studies. These mitochondria are especially vulnerable because in the hyperglycemic neurons they are the origin of production of relative oxygen species which can damage their DNA and membranes. Deregulation of fission and fusion proteins that control mitochondrial shape and number can impair health functions and might lead to degeneration. Advanced glycation and products resulting from hyperglycemia act on specific receptors, inducing monocytes and endothelial cells to increase the production of cytokines and adhesion molecules. Advanced glycation and products have been shown to have an effect on matrix metalloproteinase, which might damage nerve fibers. An increasing body of data supports a role for oxidative stress in the pathogenesis of diabetic neuropathy in animal models, which has led to clinical trials of antioxidants such as alpha-lipoic acid, a powerful antioxidant that scavenges hydroxyl peroxide and peroxyl radicals and regenerates glutathione. In these trials, alpha-lipoic acid administration improved nerve conduction velocity and had some positive effect on neuropathic symptoms. In brief, both metabolic and ischemic mechanisms have a role in diabetic neuropathies. Metabolic factor seems to prevail in LVDP, whereas an inflammatory process superimposed in ischemic nerve lesions seems to be responsible for severe forms of focal neuropathy. The thickening and herniation of the walls of small blood vessels, which corresponds to reduplication of the basal lamina around endothelial cells, suggests a role for nerve ischemia in diabetic neuropathy. Additional causes of neuropathy in patients with diabetes. Causes of neuropathy other than the diabetes itself are relatively common in diabetic patients with distal sensory polyneuropathy. In a retrospective study of 100 consecutive diabetic patients with symptomatic neuropathy and often rare features, diabetes accounted for 74% of the neuropathies in the whole group of patients and for 79% of those within LDDP. A third of patients had a neuropathy unrelated to diabetes. Chronic inflammatory demyelinating neuropathy, which was diagnosed in 9% of the patients, was the most common non-diabetic cause of neuropathy in this population. Before attributing polyneuropathy to diabetes, it's important to exclude general causes of neuropathy, such as alcoholism, vitamin deficiency, drug-induced neuropathy, monoclonal gammopathy, a condition in which abnormal proteins antibodies are found in the blood, POEM syndrome, area paraneoplastic syndrome, and amyloid polyneuropathy. Pressure pulses seems to be more frequent in diabetic than in non-diabetic individuals. For example, carpal tunnel syndrome was reported in 12% of patients with diabetes compared with the 4 to 5% of individuals in the general population. Diagnosis of diabetic neuropathy. At first, screening for diabetic neuropathy with the Michigan Neuropathy Screening Instrument. This instrument has the first part of patient version with questionnaire for patient and different features of subjective manifestations. And the second part is the physical assessment to be completed by the health professional of this Michigan Neuropathy Instrument. Diagnosis of diabetic neuropathy. In this diagnosis, the nerve conduction studies is very important. In symptomatic diabetic neuropathy, there is a slowing of nerve conduction velocity owing to diminution and loss of large myelinated fibers and a decrease in nerve action potentials owing to loss of actions. What are the basic principles and methods for studying nerve conduction and electromyography in general and in patients with diabetes mellitus in particular?
What an electrophysiologic study does is that it allows us to further assess the nervous system to see where the problem may be coming from. So with the nerve conduction studies, there are two parts, the motor part and the sensory part. Motor to check the part of the nervous system with which you move your body parts, and sensory with which you feel. And we get the responses by stimulating a nerve with a very small electrical stimulation or a very small shock. This may sound bad, but it's a very simple and benign stimulus and often feels like a tap. EMG stands for electromyography, and that part of the test is where we are looking at how well the muscle is functioning. We do this typically with the use of a needle, which is a very thin needle, and we just go under the skin and listen for electrical impulses from the muscle. This gives us information about how well the muscle is working, and depending on the type of injury or problem the nerve or the muscle has, there may be different sounds. And based on that, in conjunction with the nerve conduction studies, as well as what the patient's symptoms are, we can often make a very accurate diagnosis.
Of a diminutive neuropathy of inflammatory or dysgobernemic origin. Systematic electrophysiological testing is not necessary in diabetic patients with typical peripheral neuropathy. Changes in conduction velocity can be detected in asymptomatic patients, but their presence is not predictive of the onset of symptomatic neuropathy. Nerve conduction studies are the most objective, non-invasive measures of nerve function. They represent a valuable tool of evaluation of neuropathy in large clinical and epidemiological studies. In clinical practice, however, nerve conduction studies and CS should not be considered as a substitute for careful clinical examination because NCS have many pitfalls and their results must be interpreted in the context of clinical data. In the case of LDDP, as in all small fiber polyneuropathies, the main drawback of NCS is the small myelinated and unmyelinated nerve fibers, which are affected early in the disease course of diabetic neuropathy, do not contribute to the sensory action potential detected by routine NCS. The sensory action potential is altered only after involvement of large myelinated fibers, which is often a late event in patients with diabetes. Electrophysiological data must therefore always be evaluated in a clinical context. Diagnosis of cardiovascular autonomic neuropathy. The most commonly used non-invasive test for assessment of cardiovascular reflexes was proposed by Ewing and Clark, which includes heart rate variation in response to deep resting, standing, and Valsalva maneuver, as well as blood pressure responses to standing and sustained hand grip. These 5 tests are validated, are reliable and reproducible, correlate with each other and with tests of peripheral somatic nerve function, and are of prognostic values.
We do this by having the patient take deep breaths following a visual cue while we monitor heart rate from heartbeat to heartbeat. We analyze the beat-to-beat heart rate changes with specialized software. In the third part, we test heart rate and blood pressure responses to the Valsalva maneuver. The Valsalva maneuver consists of blowing hard into a tube against resistance. This normally causes a rise in heart rate accompanied by fluctuation of blood pressure. Heart rate is again monitored from beat to beat. Blood pressure is also monitored from heartbeat to heartbeat using specialized external blood pressure cuffs worn on the arm and fingers simultaneously. The heart rate and blood pressure changes are measured and analyzed using specialized software. In the final part of the test, we measure heart rate and blood pressure responses to tilting the patient up from laying flat to upright using a specialized table. After the patient has been tilted up, we watch their blood pressure and heart rate for up to 10 minutes. Some patients with autonomic dysfunction will have an excessive drop in blood pressure or excessive rise in heart rate, accompanying symptoms of lightheadedness or dizziness. The complete test takes about an hour. It provides in-depth information about neurologic function, which is otherwise not apparent on other common tests, such as the neurologic examination or EMG and nerve conduction studies. Our technicians perform the study in the EMG lab.
Some comments about Valsalva maneuver. During phase 1, aortic pressure increased transiently because of increase in intrathoracic pressure, and in phase 2, aortic pressure and pulse pressure decreased because of gradual decline in preload in the left ventricle. In patients with normal left ventricular filling pressure, reflex tachycardia occurred during phase 2 due to activation of the baroreceptors. In phase 3, aortic pressure declined further in response to release of the intrathoracic pressure, and in phase 4 is the recovery period in which preload in the left ventricle aortic pressure and pulse pressure increase. Heart rate tests evaluating mainly parasympathetic function appears to be abnormal more frequently and earlier in cardiac autonomic involvement, whereas sympathetic damage assessed by blood pressure tests usually occurs later and is more often associated with the clinical symptoms. The fall more than 20 milligram in systolic blood pressure after standing up seems to be the most reliable criterion for the assessment of orthostatic hypotension in the diagnosis of cardiovascular autonomic neuropathy. Measurement of the heart rate response to deep breathing may allow to evaluate autonomic function is simple, quick, and non-invasive way to general practice. Assessment of heart rate variability represents a more sophisticated method to the diagnosis of cardiovascular autonomic neuropathy. Heart rate variability is usually characterized in the time domain by the simple statistical methods and in the frequency domain by spectral analysis. And scintigraphic assessment of using 123 iodine meta-iodobenzyl guanidine and single photon emission computed tomography are more sensitive in detecting cardiovascular autonomic neuropathy than conventional autonomic function tests. According to the San Antonio consensus statement, autonomic neuropathy can be diagnosed if at last 2 of the 5 standard tests are abnormal, and reduced 123 iodine MIBG uptake or decreased heart rate variability in a patient with high normal tests should be considered as a sign of autonomic degeneration. So here we can see the normal and borderline values of tests of cardiovascular autonomic function. For Valsalva maneuver, Valsalva ratio should be more than 1.23, and the borderline is among 1.11 to 1.20, and if it is less, the Valsalva ratio less than 1.11, it indicates about diabetic autonomic neuropathy. And the heart rate variation during deep breathing, this variation should be more than 15 beats per minute, and if it's less than 11 beats per minute, it's also confirmed the diagnosis, confirmed the changes of autonomic nervous system. Also, the data of blood pressure responses to standing. Treatment of diabetic neuropathy. Preventive treatment. Prevention of diabetic neuropathy and its complications remains the best strategy. Optimum glycemic control diminishes the risk of developing of disabling peripheral neuropathy but carries an increased risk of hypoglycemia. Patients with diabetes also need advice about food care and footwear and about protection of hypersensitive areas or pressure points to prevent the occurrence of painless ulcers and decrease the risk of bone infections. Prevention and treatment of the diabetic foot are best administered in specialized food clinics. Pancreas transplantation, which might stabilize the neuropathy, is not yet routinely performed. Symptomatic treatment. In focal neuropathy, including cranial nerve palsy, PDN, and truncal neuropathy, the disease course is self-limited, with spontaneous recovery within a few months in most cases. Control of pain can be difficult both in LDDP and in focal neuropathies. Carbamazepine, phenytoin, clonazepam, or paracetamol in combination with codeine phosphate can be useful. Tricyclic antidepressants such as imipramine or amitriptyline are often effective. The usual dosage varies from 30 to 150 mg per day. Tricyclic antidepressants might aggravate postural hypertension. Duloxetine and pregabalin are also useful. Postural hypertension only requires treatment if it is symptomatic. It is worth trying midodrine where it's licensed before using 9-alpha-fluorocortisone, which is the most effective treatment for postural hypertension but carries a risk of hypertension. Treatment of focal and multifocal diabetic neuropathies. PDN is often very painful, and the pain is frequently resistant to conventional treatment. Treatment with corticosteroids for a few weeks or months can be considered in such cases along with adjustment of glycemic control. It is important to keep in mind that the overall spontaneous prognosis of focal diabetic neuropathy is good. Conclusions. Peripheral neuropathy is a serious complication of diabetes. This form of neuropathy carries a high risk of pain, trophic changes, and autonomic dysfunction. There is currently no effective treatment for diabetic neuropathy, and good glycemic control is the only way to minimize the risk of occurrence of neuropathy in patients with diabetes. Once diabetic neuropathy is present, detection of sensory loss in the feet and patient's education are necessary to prevent dystrophic complications. Other causes of neuropathies must be excluded in diabetic patients with focal neuropathies, and treatable causes must always be cited in diabetes patients with disabling motor deficit. Diabetic neuropathy is the most common neuropathy in industrialized countries, and it is associated with a wide range of clinical manifestations. The vast majority of patients with clinical diabetic neuropathy have a dysymmetrical form of the disorder that progress following a fiber length dependent pattern, with sensory and autonomic manifestations predominant. This pattern of neuropathy is associated with a progressive distal axonopathy. Patients experience pain, trophic change in the feet, and autonomic disturbances. Occasionally, patients with diabetes can develop focal and multifocal neuropathies that include cranial nerve involvement and limb and truncal neuropathies. This neuropathy pattern tends to occur after 50 years of age and mostly in patients with long-standing diabetes mellitus. Length-dependent diabetic polyneuropathy does not show any trend towards improvement and either relentlessly progress or remains relatively stable over a number of years. Conversely, the focal diabetic neuropathies, which are often associated with inflammatory vasculopathy or nerve biopsies, remain self-limited sometimes after a relapsing course. And last recommendations from American Diabetes Association for diabetes neuropathy. Recommendations for screening. All patients should be assessed for diabetic peripheral neuropathy starting at diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1 diabetes, and at last annually thereafter. Assessment for distal symmetric polyneuropathy should include a careful history and assessment of either temperature or pinprick sensation, small fiber function, and vibration sensation using an 128 Hz tuning fork for large fiber function. All patients should have annual 10-gram monofilament testing to identify feet at risk for ulceration and amputation. Symptoms and signs of autonomic neuropathy should be assessed in patients with microvascular complications. Recommendations for treatment. Optimize glucose control to prevent or delay the development of neuropathy in patients with type 1 diabetes and to slow the progression of neuropathy in patients with type 2 diabetes. Assess and treat patients to reduce pain related to diabetic peripheral neuropathy and symptoms of autonomic neuropathy and to improve quality of life. Pregabalin, duloxetine, or gabapentin are recommended as initial pharmacological treatment of neuropathic pain in diabetes. So, key points. Length-dependent peripheral neuropathy is a common complication of diabetes and carries a high risk of pain, trophic changes, and autonomic dysfunction. Optimum glycemic control is the best preventive treatment for diabetic neuropathy. Inflammatory lesions are common in focal and multifocal neuropathies. If motor deficit or proprioceptive involvement predominates, it is important to consider non-diabetic cause of neuropathy. So, thank you for your attention.